And I'm going to share the obligatory slide for the continuing medical education credits. Provided to us by St. Luke's Health System. No commercial support was received for this CME activity. Okay. There's Roger. That's awesome. And you are on mute, so unmute yourself unless, yeah, there you go.
So do we want to go ahead or do we want to give a couple minutes for the doctors to show up? Are you, how are you feeling, Dr. Gillespie? If we waited a couple minutes.
No, I think that's fine. That's totally your call. I talk fast when I get going, so.
Okay, all right. I mean, I think I'd like to wait a couple minutes and just see if those couple of docs who are, finishing their rotation can come on.
Sure.
Okay. I'm going to,
There's Dr. Bradford.
yeah, so they're coming. I'm going to share the agenda screen if that's okay with you, Roger.
Please.
And it also has a few other things on it, so. So welcome, everybody. There we have our agenda for our second session, 2 hours this afternoon. The preparation that we did ask that you complete before today's session was to meet with whatever team you've put together to work on this in your practice, to watch a 25-minute recording that Dr. Gillespie had made earlier this year, to start thinking about drafting a readiness or a sustainability plan, to attend the peer session that we had a couple weeks ago or last week, if you could, and to email a question to Dr. Gillespie. And really appreciate that a lot of you did that. We have a new one that came today, question and answer. And as you maybe recall, I'm putting those into a Word document now, or just a running Word document. It's going to be quite the treasure trove of information. So I'll update that and send that out again when I get the notes out for today. Our agenda is pretty straightforward today. And then we'll go through a homework review at the end. Hopefully we'll have a couple minutes, and we are still trying to get the dates set for our peer sessions. We're trying to coordinate between Dr. Davis, Dr. Gillespie, and Dr. Patterson, and that's been difficult enough. But now I know that you guys need to get them on your calendar too. So we're looking at a November date in a couple of weeks, and then a December date before the holiday season. Both of these will just be 1 hour sessions from 12 to 1. Time.
Terrific. Okay, well, why don't we go ahead and get started? All I really want to do is to welcome you back and introduce Dr. Gillespie. Many of you have gotten the answers from, like Liz just said. I mean, I think it really will be a treasure trove, because the answers to those questions have been so comprehensive and so interesting, I hope to everybody, or certainly were to me. I have also had the opportunity of previewing the slides to this session, and I'm just really looking forward to it, and it really looks terrific. So I'm looking forward to Dr. Gillespie. Hopefully you are too. And I know we've sort of looked at him as well. We know he is a pioneer in this particular way of thinking about ACE screening and looking at the positive childhood experiences screening as well, and that it really is that he really will bring a wealth of information and wisdom to this to this process. And so we're really happy that he's been willing to join us and be part of this, to bring what he's learned through his experience in Oregon to the work in Idaho. So I guess without further ado, I will introduce Dr. Gillespie, and it's all yours.
Thank you very much, and good afternoon, everybody. I'm excited to be here with you. Hopefully you will find this to be helpful. I know that a lot of the questions that have come through already tell me that you're thinking very deeply about this already, which is great. So some of the questions that have been asked, I think, will be covered a little bit in this presentation. But really, I wanted to kind of organize this in a couple of different parts. The first half is really about how we kind of think through why we're doing this and think through some of the controversies and barriers that you'll likely feel in practice as you do this work. And then the second half is going to be the more practical part in terms of what you're actually going to do when you find trauma, for example. And so hopefully, again, this will be helpful to everybody. Just knowing that in 2 hours, this is the tip of the iceberg. So a lot of these things that I'm presenting today we can do in a lot more depth. So whether that's future conversations or more questions that you guys send me, I'm happy to do what I can to help flesh out the rest of this information. So starting out with, and this really to me is one of the critical things to think through in terms of a frame shift in how we think about early childhood and how we think about our roles as pediatricians, and really why parent and caregiver health matters in the first place. And just to kind of fill you in on where I've been in terms of my career on screening and on what brought me to this point, I started working with the Oregon Pediatric Society in 2007, where I was working on screening for developmental disabilities and autism, and then the following year screening for maternal depression. From that, I was actually recruited into a project with the American Academy of Pediatrics, more from a medical home perspective than from a trauma perspective. The project was called Medical Home for Kids Exposed to Violence. There are a lot of materials on the AAP website that came out as a result of that, which I can direct you to later. But that's really where I read about the adverse childhood experience study in the first place. And that's when one of my partners and I decided that we needed to actually do something about it. So we started assessing parents for their ACEs and their resilience in 2013. Since then, we participated in some projects that looked at specifically social determinants of health and social emotional screening. And then more recently started working on really building those universal resilience interventions that I've mentioned in the previous videos and in some of the emails, and really switched last year to asking about parent positive childhood experiences, which we'll talk about a little bit. And certainly from a provider perspective, it looks like an awful lot of screening tools and an awful lot of pieces of paper that we're giving to parents, which to some degree is true, but the frame shift that really needs to happen is figuring out how we weave those things together. Those different screening tools need to, in our brains, be thought of less as individual data points and more as an overall picture of how a family's functioning. And I think that the thread that we're weaving this all on really is social emotional health. And if you think about social emotional health, it refers to a child's ability to form secure relationships, experience and regulate emotions, and explore and learn. And if you could think about that last point in particular, explore and learn, this means that all of a child's other developmental milestones, their ability to achieve gross motor and speech and so forth, is dependent on their ability to explore and learn, which means it's dependent on their social emotional health. Now, just in terms of terminology, social emotional health is really the child-centric interpretation of it. Early relational health is referring not only to that first 5 years, but also referring to how that social emotional health develops in the context of a caregiver relationship and how that caregiver relationship is necessary to promote appropriate social emotional development. Why we focus on early relational health in the first place. So a child's developmental trajectory, both positive and negative, is dependent on their early relationships, primarily the relationship with their caregiver. Problems in early social, emotional, and behavioral development predicts early school failure, which actually predicts later school failure. There are studies that actually look into the ability to predict at kindergarten entry which children are going to drop out of high school, which is kind of scary when you think about it, but that means that early relational health is vital for lifelong success. Intervening early obviously helps to prevent the need for later and more expensive interventions, both in the educational system and in the mental health system. And when you ask parents, social emotional health significantly contributes to kindergarten success, but is also the area where parents feel like they need the most support. and get the least support from their providers. So in terms of what gets in the way of early relational health, the first, environmental risk factors, so unsafe communities, lack of resources for parents, poor quality childcare, risk factors within the family, so parental depression, adverse childhood experiences like household mental health or substance use, poverty, intimate partner violence. And then there are child factors that can get in the way of early relational health as well. Think about a child with a difficult temperament, like colic, for example, kids that have chronic medical problems, particularly prematurity, where parents don't have sometimes the opportunity to physically and emotionally bond with their kids because they're in the neonatal intensive care unit for so long. Developmental delays also can play into parents' ability to bond with their children and promote that social emotional health. At this point, you all know about adverse childhood experiences, so I'm not going to belabor this particular point, except to say that when Dr. Felitti and Dr. Anda initially did this study on adverse childhood experiences, they initially looked at a couple dozen different adverse childhood experiences. And when they published their study on these particular 10, it was really because those were the 10 that were in their study found to be the most impactful in terms of lifelong health and wellness. However, we know that there are actually dozens of different traumas that can affect a person. In fact, the National Child Traumatic Stress Network identifies 2.5 dozen, I think, different stresses. And so the thinking in some areas is really moving away from adverse childhood experiences specifically and thinking about stress and toxic stress. And this is a taxonomy of stress that's been provided by the Harvard Center for the Developing Child, where if you think about normal, tolerable, and toxic stress, normal stress are the everyday pressures that push us to perform. They're temporary and have an activating effect. So in other words, things that we do in our day-to-day lives, public speaking, for example, doing presentations, for example, would be normal stresses, and that little bit of stress pushes us to do a better job and to actually perform. Tolerable stresses are things that are negative events that are usually temporary or one-time, but that are well buffered by coping strategies and by the support of those around us. What makes something a toxic stress as opposed to a tolerable stress is oftentimes that it's chronic or repeated stresses. They're often committed by those who are supposed to be supporting us, and they overwhelm our capacity for coping. And so it's some of these negative events that are not buffered by coping strategies or by supportive relationships. The toxic stress level is associated with physiologic responses that lead to the lifelong health and wellness concerns. Many people are looking now at the pair of ACEs, and so this is just put up here to kind of open your thinking a little bit, that we have the traditional adverse childhood experiences as the tree in this diagram. So again, the abuse categories, neglect categories, household dysfunctions, and so forth. But then the adverse community environments are the roots of some of these adverse childhood experiences. And so we look at things like poverty and discrimination, poor housing quality, community violence, and so forth as being similar to the ACEs in that they can trigger that toxic stress response in a person because it's a chronic and repeated stress, and it can trigger physiologic changes in a person. If you think about all of the effects of recurrent or persistent exposure to trauma, the studies are pretty clear that it changes our brain architecture. It changes the way our genes are expressed by altering the epigenome or the controller proteins for the DNA. It changes our endocrine and immune systems. It decreases our ability to use our good thinking skills and our executive function. It decreases our ability to affect our regulation of our emotions. And it interferes with relational health. And these cumulatively are what lead to the chronic illness, health disparities, and decreased quality and length of life. What we're finding in more recent research is that positive childhood experiences are actually more predictive of health outcomes. And this is why this conversation has changed to not only thinking about ACEs specifically, but also thinking about positive childhood experiences. And this comes out of National Survey of Children's Health. Particularly, they did some work in Wisconsin where they added ACE and positive childhood experience questions to the behavioral risk factor surveillance system. And they found that the presence or absence of positive childhood experiences, again, were more predictive of health outcomes, to the point where somebody who has a lot of adverse childhood experiences, but also has a lot of positive childhood experiences, actually has better mental health outcomes than someone who had neither ACEs or positive childhood experiences. So the absence of these positive childhood experiences are, again, going to determine a lot about a person's health and wellness. Now, if you look at what these adverse childhood experiences or these positive childhood experiences are, they're all related to relational health. So you have a family that listens to your feelings, they stand by you during difficult times, you have a community that supports you in the relationships within a community that leads to community traditions. You had a sense of belonging in high school, meaning that you connected to a peer group and connected to teachers. You felt supported by friends. You had non-parent adults who took a genuine interest in you, and you felt safe and protected by an adult in your home. Again, what that means is all of these positive childhood experiences are really relational health experiences at their core. Now, as pediatricians, we want to get as far upstream as possible and try to avoid all of those health outcomes that are associated with ACEs. And this is really the reason that we started looking at parent adverse childhood experiences in our practice, is that we wanted to try to get to the idea of prevention. And so to think about that, how do we as a profession both prevent ACEs and promote positive childhood experiences if parents don't at least know what these things are? When the American Academy of Pediatrics came out with their policy statement around the role of the pediatrician in addressing toxic stress in practice, this was the 2012 recommendations. There's an update to the policy statement that came out last year, but says very similar things. The four main points are that pediatric medical homes should strengthen their provision of anticipatory guidance to support children's emerging social, emotional, linguistic skills, and to encourage the adoption of positive parenting techniques, that we're supposed to actively screen for precipitants of toxic stress that are common in our practices, that we're supposed to develop, help secure funding, and participate in innovative service delivery adaptations that expand the ability of the medical home to support kids at risk, and to identify or advocate for the development of local resources that address those risks for toxic stress that are prevalent in our communities. This is an extremely tall order, right? We certainly, I think that the first one we can nail. We can do anticipatory guidance and we can do positive parenting and so forth. The rest of them get a little bit complicated, in particular because what was missing from that policy statement was a roadmap. And so when we started our parent ACE screening in 2013, we didn't have any sort of guidance as to how we were actually supposed to do any of those things that were mentioned in the policy statement. For example, who do we even screen? Is it kids after the ACEs have happened? Is it parents? What are we screening them with? When do we do it? How often do we do it? And then most importantly, what do we do when we find it? And so all of these questions were really sort of left lingering after the policy statement. And, you know, when I first read this particular policy statement, it was the first one that I've ever read in 21 years of practice that made me think, this is an important thing, right? Like most policy statements are kind of dry, but this seemed like a very important issue. But again, without a specific set of directions on what to do. So when we started looking at parent trauma and why we think parent trauma matters, this is what was in the literature. The first is that there are correlations between parent ACEs and their child's eventual ACE score. So the more ACEs a parent experiences, the more ACEs a child is likely to experience. Now, we know that those ACEs are not inherited in a linear fashion. So someone who is physically abused doesn't necessarily become a physical abuser themselves, for example, but they might experience more depression, substance use, or relationship problems that then become the ACEs for the next generation. That said, in the psychology literature, parenting styles are at least in part learned, so that if a parent experienced harsh parenting, they're more likely to engage in those harsh parenting styles themselves. This mostly comes down to modeling, right? Like our biggest role models for becoming parents are our own parents. So however they treated us is likely how we're going to think it's supposed to be done. And particularly when you're under stress, you tend to revert to what you know, right? Those familiar patterns that you know are going to be a lot easier to walk on than a path that you have to forge for yourself when you're under stress. Third, and this really to me was a mind-blowing study. When I was in school, we were basically taught that all the brain growth you're ever going to have happened in the first 3 years, and then after that, it was a lot of pruning of your neurons, but that was kind of it. But since then, the field of neuroplasticity has kind of blown up, where we know that there is new brain growth at a lot of different times in a person's life, but in particular, and this comes out of University of Denver and Pilion Kim's work, parents have new growth in the first 6 months after their child's birth, both in the amygdala, which is their emotional center, the fight or flight center, and in the frontal cortex, which is the logical center, unless they're experiencing some kind of stress, in which case the amygdala develops and the frontal cortex doesn't. And the types of stresses they were looking at were things like domestic violence and food and housing insecurity, in which case you're likely, if you're a parent under stress, to have a physiologically, emotionally reactive brain without the ability to regulate it. So we think that this is a physiologic reason why some of the harsh parenting styles actually happen. The other piece for me, and this comes out of Roy Wade's group in Philadelphia, he says that kids who experience 3 or more ACEs before entering kindergarten have lower readiness scores, lower kindergarten readiness scores. So not only do they have differences in their literacy, language, and math skills, but they also have much higher rates of behavior problems. And if you think about the first half of this sentence, that kids have 3 or more ACEs by the time they're 5, that to me is kind of like a record scratching kind of situation. Like, wait a minute, how are these kids having so many experiences before the age of 5? That means that we have to do something to intervene early, right? And if you look at studies about when ACEs happen for somebody who has high ACE scores, they usually picked up 2 ACEs by the time they're 3, another ACE and a half by the age of 6, and another ACE and a half by the age of 12. And so people with high ACE scores, most of those really are happening in those formative years before they even enter kindergarten. Now, in my practice, we started looking at some of the outcomes specifically associated with parent ACEs. The first thing we looked at was developmental delay and the risk of failing your developmental screen by age 2. And you can see that with each maternal ACE, there's a slightly higher chance of failing your developmental screen by the time you turn 2. Father's ACEs were a little bit more predictive, but we didn't have enough patients in our study to really extrapolate it all the way out. But you can see that the rates for dad's ACEs are a little bit higher in those first couple of categories. And looking at it even further, the combination of prematurity and parent ACEs, particularly dad's ACEs, were extremely predictive, right? So that if a kid was born before 37 weeks and mom had 2 or more ACEs, they were a little bit more likely to fail their developmental screen. But if you can see on here, if dad is the one with 2 or more ACEs, then they're almost 8 times more likely to fail their developmental screen by 2. Now, I had a colleague who once told me that this must be toxic masculinity, which is one theory. But I think a more important theory is that moms are more so than dads able to identify people in a support network who can help them out when they're stressed. Moms, if you ask them, they can usually give you 3 to 5 people in their support network. Dads, it's 0 to 1. And the 1 is usually mom. And so I think dads are fairly isolated in terms of their parenting experiences and really don't talk to anybody about how to do parenting. So as far as I'm concerned, that's partly what we need to do to the best of our abilities, as much as dads show up, right? Now, some other studies looking at parent ACEs. The first one said that compared to kids whose parents have no ACEs, a child whose parent has 4 or more ACEs has a higher score on a behavior problems index. They have higher rates of hyperactivity and higher rates of emotional disturbances. This one, the correlations were stronger for mom's ACEs than dad's ACEs, but these are pretty significant numbers. In terms of general health outcomes, there were worse rates of asthma with each additional parental ACE, worse overall health status, worse parenting practices with things for things like excessive media use. Since these are cumulative effects, for example, if a parent had 6 or more ACEs, their kid was over 6 times more likely to have asthma. And the second study that we put out was looking at parent ACEs and utilization patterns. So for each additional maternal ACE, there's about a 12% increased risk of missing well visits in the first 2 years. which means that kids are not getting their anticipatory guidance on developmental promotion on time. They're not getting screened for developmental delays on time and so forth. In my practice, the policy when I first started was that if a person had a certain number of missed well visits or missed appointments, that they would be discharged from the practice. But as you can see, that's not particularly trauma informed, because we can see that most families who are missing visits probably have a high ACE score. So what? So we think that the correlations between parent trauma and their child's developmental and behavioral outcomes are due to disruptions in that early relational health. Therefore, in order to promote healthy social emotional development, we really have to assess barriers that are experienced by the family. So for example, parents who have experienced ACEs, particularly in the absence of positive childhood experiences, may not have experienced appropriate modeling and positive parenting, self-care, and an understanding of normal childhood development. Parents who experience social determinants of health may be physically and or emotionally unavailable to build relational health with their kids because they're working 3 jobs, or because they're struggling to get food on the table, and so they're emotionally distracted, right? And then parents who experience peripartum depression or anxiety may also have challenges observing and responding to infants' cues, and may not have the energy to actively promote their child's development. That means that as pediatricians, we have to be looking at these 3 areas, in my view. Garner and Saul, in their book Thinking Developmentally, put it this way: it's hard to be in relational mode when you're in survival mode. And I think that's the best summary of what we've just been talking about, that if parents are in survival mode, they're not going to be able to promote their kids' early relational health. And so promoting safe, stable, nurturing relationships in caregiver-child dyads requires careful support of caregiver health and wellness. So what we've been looking at so far in practice is a long list of different screening tools that we're supposed to be doing at a lot of different visits. And generally against the mindset is to do each of these screens. Did I do them? Did they pass or fail? Do I refer or observe? And then do I move on? And what we really need to do is look at these screening tools from an integrated perspective. If you think about everything on the background of developmental health, and then think about things like social determinants, parent ACEs, and maternal depression, you're going to have a different workflow for each of these combinations. So somebody who has a child with developmental delays who has social determinants, you're going to have to address that before you can do anything about developmental health. Parent ACEs and developmental health are probably going to require some positive parenting and some resilience building things. Maternal depression and developmental health means that you're going to have to do some referrals for the parent who's experiencing depression. And all of those workflows would be very different than a family who has a developmental health concern without any of these different things. And really at the center of that, again, is going to be social emotional health, where all those things intersect. So in terms of how we support families, that means we need to first of all screen for risks. Second of all, figure out strengths and figure out how to support resilience, and then refer when needed. But more importantly, I think this requires a change in the culture of practice. Most parents don't really think these are things that they can be talking to their pediatrician or their provider about. And so we really need to think about how the culture of practice has changed. I would start with the idea of radical acceptance, that we suspend judgment, blame, and stigma for any of our patients and really do our best to meet them where they are, understand that they are doing the best they can and that we can support them to do better. Second is really realizing and recognizing that children develop in the context of a healthy family, and that resilience is learned and improved upon only in the context of relationships. I think there's a mythology about resilience being about grit and me pulling myself up by my own bootstraps and doing it on my own. Resilience really is something, though, that is learned in relationships, and it can be taught. Now, that's the frame shift. Now we're going to talk about the catch. Certainly when we started doing this work almost 10 years ago, it was novel. There wasn't a lot in the literature, again, as I said, about what to do about it. Since then, there's been a lot of controversy that has been put out because a lot of people have jumped on the ACE screening bandwagon. And we need to understand those particular concerns in order to do ACE assessments effectively. There are also, I think, barriers within practices that we need to think about as well, and how we address those particular barriers. So that's this part. And I'm in the process right now of writing a book about how to do assessments for trauma and respond to trauma for the AAP. And it really, in part, came out of California and what California is doing. So as many of you probably know, Nadine Burke-Harris, who wrote a lot of the original stuff about ACEs in pediatrics, and wrote the book, The Deepest Well, to talk about how trauma affects kids. When she became the Surgeon General of California, she decided that she wanted to have universal ACE screening and that there is reimbursement for completed ACE screenings on Medi-Cal. So their version of Medicaid, anybody who completes a screening tool on a patient gets $26 for doing that screening tool. Now, to my mind, given that, for example, developmental screening tool on Medicaid in my state is $6, $26 is a lot of money for doing ACE screening, right? The legislation defines a positive screen as being a score of 4 or higher. And so 4 or higher is marked as a positive, less than 4 is marked as a negative. I'm sure you all know, and we're going to talk about this in a second, that's a little bit minimizing to some of the experiences that some of these people have. And the providers, in order to get ready, take an online self-directed training to certify as ready to screen. Now, if you kind of think about how that's rolled out as a top-down rather than as a supporting practices on the ground, you can see how harm can happen in that kind of context. And that's really where we're coming from. And so the debate around ACE screening specifically comes from a number of different places. The first is that the ACE questions were originally developed as a survey research tool, right? So they were given out to patients in the Kaiser system. It was not a clinical tool, and it was not developed as a screening tool specifically. As I mentioned earlier, it's missing a lot of potentially stressful events and gives equal weight to experiences regardless of the timing, intensity, or frequency of those events. So for example, someone who was chronically sexually abused has the same ACE score as someone whose parents were divorced. That's a problem, right? At a population level, it is predictive of health outcomes. It is not, however, very predictive of health outcomes at an individual level. And that mostly has to do with the presence or absence of positive childhood experiences, which is why that comes back into the conversation. It's seen as a deficit model, meaning that we're talking a lot about what's happened to a person in a negative sense, but not really balancing that with any sort of message of hope or message of positive childhood experiences or anything else. As of now, there's not a lot of evidence around interventions that work. And then let's get even back to the question of what screening actually means, right? Because screening implies that there's mutual discovery, both on the part of the person completing the screen and the provider who's interpreting it. And really, when it comes to getting somebody's ACE score in particular, the parent or the patient knows exactly what's happened to them. So it's not a mutual discovery kind of thing. So, you know, there's some question marks even about the language, that these are assessment tools, they're not screening tools, because one person isn't learning anything new. So enter the AAP and some of the policy comments that have come out since. And this is partly, I think, in response to that California experience. And that's not to denigrate what they're doing in California, because I think it's very important from a public health perspective to be raising awareness around ACEs. But the sort of summary statement says that instead of summing the suffering, we should be building the buffering. So instead of just counting an ACE score, we need to figure out how we actually build resilience in families and in patients. And part of that is really balancing that discussion of the effects of ACEs with a message of hope. So the caveat is that assessing ACEs in practice, according to the AAP, can be a part of an overall trauma-informed response, but we have to be paying attention to how we avoid harm and how we build resilience as a part of that. So if we're screening without a response, or if we're screening without talking about positive childhood experiences, that's not adequate and that's not enough, right? In my view, and certainly in the view of those in the AAP who write these kind of policies, you can use the assessment tools as a teachable moment, right? So from my perspective, the goal of doing these assessment tools is not to force a disclosure of trauma. It's less about the answer and more about how we educate families and how we create a change in practice culture. So I want you to really think about that particular point, that we're using the tools to educate people. Now, this again comes from Andy Gardner's book, the one that I mentioned earlier, Thinking Developmentally. And when you think about public health and levels of prevention, at the bottom, primary prevention are the universal preventions that we do for all families. So anticipatory guidance, consistent messaging about trauma, helping families to understand what trauma means, right? This is how we promote safe, stable, nurturing relationships, by building 2-generational relationship skills. Now, I see an assessment tool as being part of the universal prevention, because we are talking to everybody about trauma when we do these assessment tools. That's number one reason why I think it's important. Secondary prevention is where you start to look for those potential barriers to safe, stable, nurturing relationships. So this comes down to, are we looking for social determinants? Are we looking for patient and child ACEs? These things allow us to identify which families might need extra help. So this assessment tools are the first, or maybe the second part of the public health response, in that we're figuring out which families might need some more help. I'm going to get to how you break this down in a little bit. But then the third part, in terms of tertiary treatment, these are the treatments for toxic stress-related symptoms and diagnoses. So using the assessment tool, not only to figure out who's at risk, but also following that up with how you decide who needs further treatment. And this is all about repairing strained or compromised relationships. This is alphabet soup for different therapy types. So attachment and biobehavioral catch-up is the ABC. Parent and child interactive therapy is the PCIT. Child and parent psychotherapy is the CPP. And then trauma-focused cognitive behavioral therapy is the TFCBT. All right. So these are different known evidence-based modalities. That's for later, but just so I explained what all those abbreviations are. So my approach and how we make ACE screening work from a practical perspective: first of all, think about healthcare ethics. Second of all, be prepared to manage and address resistance from within the practice. Third, commit to discussing every completed assessment tool, and we'll talk about this a lot as we move on. And then finally, developing a solid work plan, including a plan for what to do with the results. The first principle of healthcare ethics is non-maleficence, right? Like not doing harm. And really, I think this comes from a couple of different places. First of all, the message of silence, right? So if you don't respond to the screening tool, then you've just told a person who's disclosed something to you that they're not safe, that this is not a safe place talking about this. And I bring this up in particular. There are two stories to share with you on that one. The first, when I was doing developmental screening training for providers, I met a lot of providers who would do their developmental screening tool, and they were really bogged down at the end of the day by having to go back and contact families who had failed the screen to get them referred to early intervention, which meant that they had a pile of screening tools at the end of the day, and they had not talked about a single one at the point of care. I don't think you can do that with any kind of trauma assessment. I think you have to really be careful about responding to all of them at the point of visit. There's an editorial, and this is the second story, by a woman, her last name is Austin, and she talks about the experience of having been screened for sexual abuse in her history on several different occasions by her primary care provider. And her primary care provider never said a word about it, not only at the time of visit or in any subsequent visit, even though I think she had completed the tool 2 or 3 times. That is harmful to families to think about disclosing something sensitive and not having a response to it. Second thing that I think we need to think about is how we label patients and families and how we protect privacy and confidentiality. One of the things that happens in California is, in order to get the bill, you put, or to get the reimbursement for the completed tool, you put in your Medicaid billing, whether it was a positive or negative screen, right? So that means Medicaid knows which families have high ACE scores. From a public health perspective, that's probably of great interest, but at an individual perspective, that's not very thoughtful about their privacy and confidentiality, in my view. I think it's also important when we do this to remember who else might be harmed. You know, providers and staff are going to come with their own ACEs, and there is concern about secondary trauma for people who have experienced ACEs if they're not supported during this process. So again, first ethical principle to think about is not doing harm. Second, beneficence, to the idea of doing good. So I think this really gets down to thinking about why we're doing screening, and it better be something better than just getting paid for it, right? So my view is I'm trying to help families to be better parents, and I'm trying to figure out how to help them with their parenting skills, how to build their resilience, and so forth. So the good that comes out of the assessment is connecting families with resources, giving better and more empathic care to the families, I believe, creating a stronger relationship with the family, and potentially being able to prevent trauma. So this is my North Star in terms of what I'm trying to do with these assessments. Autonomy. And this really comes down to letting the patients decide. When you ask patients and parents in particular about disclosure and the process of disclosure, they don't see it as a discrete event. They see it as a process that maybe they'll tell you a little bit of their story at one visit and a little bit more at the next and a little bit more at the next. But it is always up to the patient about whether they say anything at all. And I think that we have to be very transparent about whether or not they complete the assessment in the first place. But second of all, how we discuss that assessment as well. And this is one of the sort of subtleties that you'll figure out both with social determinants screening and with parent ACE screening, is that if a parent is completing an ACE tool on their, at their child's 4-month visit, and they have a grandparent there with them, or they have an 8-year-old there with them, that might not be the time to actually discuss that. And so our tools actually have added in a, how do you want to discuss the results right now? Or do you want me to call you later? Or how do you want this done? So that parents have some choice about how the tool is discussed. I think also for us, we spend a lot of time figuring out how to maintain privacy and confidentiality in how information is documented in our electronic health record. We have a confidential field in our EHR that allows us to put information in that is there for us to see it, but it doesn't print into notes, which is how we protect confidentiality for parents. I think one of the big things that parents are fearful of, and we'll talk about this again in a second with barriers, is the idea of being reported to a government agency. And I think that when you're talking about parent ACEs, it's important to be explicit to families that this is not going to be reported to any government agency, and saying those words out loud will actually help parents to feel a little more comfortable with what we're doing. Fairness. And I think this really gets into social justice a little bit. Illnesses and behaviors that contribute to health disparities are correlated strongly with trauma at an individual level, a family level, and a community level. And there's a huge overlap with trauma and social justice, in that trauma is experienced more often in communities of color. And there's a whole lot to be said about historical trauma that has significant impacts on certain populations within the US. These populations have real and valid reasons not to trust us as healthcare providers. And I think we need to be respectful of that. I think that it's important for everyone who is doing this kind of work to spend some time looking at diversity, equity, and inclusion training, and how we make sure that our clinics are not mirroring the trauma that is experienced by patients, because we may be, again, perpetuating some of that trauma as well if we're not thinking about these particular issues. I think there's an opportunity to use trauma assessments to elevate disadvantaged populations and to address disparities in care, but it does require some particular thought to that. I have some resources for that. So if somebody's interested in looking at some DEI training resources, I have a couple that I can send to you, so let me know. Now, getting into sources of resistance, and I know I'm talking very fast, so hopefully everybody's doing okay. This survey was one that I sent to a lot of the providers in my office when we were starting to do parent ACEs. I got about 2/3 of them to respond. We looked at another group that was about to start screening to talk about what are they most afraid of, and where do they think they're going to run into problems. And so I would imagine that a lot of you are feeling the same way, that these are the things that you're worrying about, right? The big picture, though, is that providers generally disagreed that parents were unwilling to discuss ACEs. Our parents, by and large, have accepted this very well. They agreed that ACE screening provided important information for providing care, and they disagreed that time was a barrier. We're going to talk about this in just a second. The comfort with discussing ACEs was mixed. So before starting to screen, what is or what was your greatest fear? And I'm sure you guys, again, could guess this off the top of your heads. Time was number one, followed by not having resources, followed by the idea of having a visit go completely off the rails. And they talked about either opening a can of worms or opening Pandora's box, not knowing what to say, not feeling confident, triggering a full emotional or mental collapse on the part of the parents, or that they wouldn't be able to help, right? And when we asked them, has what you feared actually happened? Universally, the answer was, well, almost universally, it was no. There was one person who said yes and one person who said somewhat, and they were talking about their lack of confidence as their greatest fear. So in terms of all those other fears about time and parent collapse and things like that didn't happen. How has ACE screening changed your practice? Better insight, improved communication. I know the parents better. My office is a safe place to talk about things. I have more empathy for my patients. There's no subject off the table, cultivates a trusting relationship, and I have a better understanding of the forces shaping parental responses. All of these are beautiful, wonderful things to have going for you in your relationship with your family. So this, I think, is one of the things to kind of keep in mind, that once you get this really embedded into your practice, you're going to have a much deeper and more respectful and more empathetic relationship with your families. And that is, again, a wonderful thing. When I asked, was it as scary as you thought? Universally, they said no. So getting into each of those big barriers one at a time. The first one, in terms of opening a can of worms, we'll talk about, and then provider confidence, lack of resources, and parent perceptions. Again, these were all the things that people are most commonly worried about. And really, again, getting into the idea of kicking a hornet's nest or opening a can of worms or whatever, the first thing to remember is that listening is therapeutic. We're going to talk a bit more about this, and I'll give you some data to prove that part in just a minute. One of my mentors put it this way: when something becomes speakable, it becomes tolerable. So when you take a traumatic experience and put it into your logical brain, where you're talking about it, writing about it, journaling about it, whatever, it's called a trauma narrative. And what that does is it starts to organize and override your emotional response to it. And so it's really drawing that connection between your emotional brain and thinking brain. And that's the first step towards healing and integrating your experiences. If you think about motivational interviewing, there's the idea of the writing reflex, where providers are trained to fix whatever problem is in front of us. It's about righting the ship, right? So whatever's wrong, it's our job to fix it. Oftentimes, a solution to patients' problems can be found within the patients themselves if we take the time to ask. It's important to think about self-care during this and putting on your own oxygen mask before helping others, and to think at your core that your key message is something along the lines of, you're not alone, it's not your fault, and I will help you. And you will be able to navigate most of the difficult conversations that you have. Now, the time factor. Feasibility studies and screening for ACEs show that the conversations usually last 3 to 5 minutes at the most. And that's been a common finding across pediatrics, family medicine, and OBGYN practices. And that's because the majority of the time, the provider's the only one learning something new, right? The family already knows what's happened to them, right? And most of the time, the immediate plan is not changed by a disclosure. So that at least 75% of the time, that we don't offer anything because the families don't need it or don't want it. And so at the end of the day, we're the ones that change, right? The first thing, in my view, about managing time is recognizing where the patient's mental state and emotional state is. So if a patient is regulated, meaning that they're calm, they're attentive, they're leaning into the conversation, then you can focus on education and providing resources. However, if you start talking away at somebody who is dysregulated, so if the parent's upset or angry, they're not going to hear what you have to say. So in those cases, it's best just to go to reflective listening and empathy. So just letting the family tell their story. The next step in terms of managing time is to really triage the rest of the visit. So what needs to be addressed today, which is probably the trauma and a safety plan. And then what can be addressed at a follow-up visit, right? So imagine that you are at a 4-month visit, you're asking a parent about their ACEs, and you say something along the lines of, cool, thanks for sharing. Now let's talk about car seats, right? Like that's not appropriate. So think about what you can manage at a different appointment, right? Like I think that as providers, we're in this mindset that we have to just absolutely do everything on our checklist at a certain visit, but we can break that up. That's okay. I have always gone by a set of 3 conversation prompts that help me to focus the conversation. And that to me actually puts guardrails on the conversation so it doesn't go too far out of control. And these conversation prompts have helped me on all of my visits. So the first thing is to really thank the parent for sharing the experiences. You know, I think it's important to validate those experiences. And so saying something reassuring, just thank you for sharing these experiences. I know that can be scary to open up about this. Use your own language, right, to how you thank the family and acknowledge that experience. But then my 3 questions are these. Do any of these experiences still bother you now? And this gets at immediate safety needs. So if the family is having a particular problem that requires a mental health provider, for example, this is where that comes out. And it's happened, I think, about 5 times in 10 years. So it's not the most common response by any means. Second question, of those that don't bother you, how did you get to the point that they don't? And this question really gets at resilience. So what are the strengths and resiliences that parent carries with them, and are they still around? You know, do they still have the coping strategies? Do they still have the family members who helped them through it? Do they still have a therapist, if that was what it came down to? So that you can kind of start assessing whether those resilience skills are still there and whether we need to buffer up those particular things. And then the last question for me, how do you think these experiences affect your parenting now? And this really, again, helps people to start thinking through, okay, so maybe when my kid's yelling at me, you know, I take it wrong or it triggers my stress response. Let's think about how we do that differently. The vast majority of the time when I have someone who's experienced ACEs, when I ask them how they think the experiences affect their parenting, their almost universal response is, I just want to do better. I want to do something different than what my parents did for me. And then I close with, thank you for sharing this. We'll keep this information in mind as so-and-so grows and develops so that I can help guide you through some of your parenting challenges, right? And that's it, right? So this again is how I've managed 99% of the conversations throughout the years. This will help, okay? In terms of building provider confidence, I think that it's with anything in medicine that confidence comes with time and with practice. So that's been shown in family medicine studies where they just see an increase in confidence the more you do it. And I would just encourage you to think about the fact that we have difficult conversations all the time, and we don't always have the answers. I've had 5 kids over the last 21 years that had a brain tumor. What was my role in that? It wasn't to take out the tumor or to provide radiation or do the physical therapy afterwards. It was to sit with the family through that difficult time and come up with an interval plan in terms of what's going to happen next, right? I think that some of those necessary skills include building relational trust. So how we actually manage the visit in terms of how we communicate our empathy and our concern for our families, how we regulate our own emotional state, right? Particularly if we have experienced trauma ourselves. And then the idea of reflective practice is really spending time thinking about cases, either individually or with a group, and I would suggest definitely with a group, to see what went well and what didn't go well and how you could do that differently. In terms of managing confidence, I do think that motivational interviewing is one of the ways to kind of get you through that. So again, some of those interviewing skills are going to be about asking open-ended questions, asking the patient or parent what they think would be helpful, and really putting aside our writing reflex. I think that our role, again, is primarily around listening and how we listen effectively to our families. And this is partly because trauma is usually inflicted by authority figures, and we as providers are authority figures, whether we want to be or not. And so when, as an authority figure, we can listen with compassion, we actually help families to heal. And when in doubt, the common factors approach, which comes out of the AAP's mental health toolkits, is a good framework in my view. This is the common factors approach. It's the mnemonic HELP. I'm not going to read this all to you, but I'm going to point out a couple of things. Empathy, obviously, listening attentively. Loyalty, that you're expressing your support to the family and your commitment to help. Permission, I think, is an important one as well, just in terms of asking families permission. And this is why we say, do you want to talk about this in the visit or some other time, or how do you want to do this? And then the last part on here is the plan, or at least figuring out an incremental first step for what we're going to do next. In terms of parent resistance, the short answer is usually not, but it depends on how we approach this in practice in the first place. So first of all, there were focus groups of parents that were done where they were asked, like, how do you feel about screening for ACEs and for toxic stress in practice? And parents generally were comfortable with the questions about trauma. They get it in terms of why we think this is an important issue. They do often see their pediatrician as trusted change agents and as a bridge to needed services, and they usually don't even mind the results being recorded in the chart. In a family medicine study, there were no patients that actually refused the screening tool. So parents and patients may not be as resistant as you think. That said, there was a pretty interesting focus group that was done specifically around social determinants of health. And if you think about what parents are fearing, first of all, they're fearing judgment and discrimination, and that comes down to how we manage the conversations with families and how we treat the families in our office. They're fearful of an intervention by Child Protective Services or another government agency. They're concerned about the lack of time during appointments. This gets down to the permission part, right? Like if you, and this was, the specific comment was around, say you come in for an ear infection or a sore throat, and then you're getting asked questions about social determinants. That's not what parents want to talk about, right? So getting permission to talk about these things so that they feel like their needs are being addressed first and foremost. And then the last thing that parents fear are the idea of a double loss, that they'll disclose sensitive information and not get help. And that again is referred to as a double loss. So that's one of the things parents fear. So how we engage parents and patients. First of all, develop a scripting tool for the front desk or whoever's handing out the tool that explains what the tool is, that it's universal, that we're not picking on you. It's something we ask everybody. And that talks too about, like we do a cover letter on ours that discusses why we think this is an important topic and what we're planning on doing with the results. As I said, thank parents for sharing the information and just validate how challenging that disclosure might be for them. Be sure to discuss all tool results, like I said, at the point of service, because the unintended message of silence is powerful. That tells the person who's doing the disclosure that they're not safe or that you don't care. So it's really important to make sure you commit to that. As I said before, goal of screening isn't to force a disclosure, but to provide a safe environment for parents and families and to educate about trauma itself. Now, the listening part, and I think this is really important data to kind of think through. This comes from the Survivor Voices study, which is done by some folks in Eugene, Oregon, where they actually asked survivors, what made you better? And when survivors said that they'd been listened to with compassion, they were almost 3 times more likely to report being mostly or completely healed. When survivors believed that people understood the impact of trauma on their lives, they were over 2 times more likely to report being mostly or completely healed. And when survivors believed that people knew how to help them heal, they were over 2 times again more likely to report being mostly or completely healed. This really comes down again to the power of listening. There's nothing magical about this. This is in your toolkit. You can do this. Vince Felitti himself found that asking and listening was in itself a very profound form of doing. So in terms of what you're doing for the families, you are giving them the space to talk about their experiences. In terms of the resources, and we're almost to the break, it's important to have specific resources ready, anchored to the tool you're using. But I would encourage you to think beyond mental health referrals and think about what parents or patients need or want. The best way to know that is to ask them. So if a parent has disclosed trauma, you can ask them very simply, what do you think would be most helpful right now? Okay. When asked collectively, in my practice, the patients who'd experienced ACEs were most likely interested in parenting classes or parent support groups, or on information about trauma and its effects. And if you think about the AAP policy statement, remember it said that we should be focusing on positive parenting skills and on developmental promotion. That's still in our wheelhouse. For us, we have some local parenting classes, support groups, mentorship programs, home visitation programs, and other things like that that will help to build parent skills and confidence as a response to that. So again, beyond mental health resources, think about those particular resources. That's most likely what parents are going to ask for, is for the parenting support. Modifiable resilience factors in pediatrics. Again, this is a study that came, or a review article, I should say, that was in Pediatrics in 2017. And amongst those things that were most impactful, first of all, positive parent skill building is on the list. Working on maternal mental health problems was on the list. Doing self-care skills and routines in terms of building resilience and building self-care also on the list. And then enhancing trauma understanding. So just that process of educating about trauma, these are the things that are going to be most helpful. Basic clinical response is going to be these 4 steps: figuring out if the family's safe, figuring out what resources and resiliencies exist within the family, figuring out what follow-up tools you need for assessing mental health and development, and then connecting with appropriate resources. We're going to go into this in depth in the next part, but let's move to questions for a little bit. I see some stuff in the chat. Okay.
Questions? Do people
Yeah,
have
let's hear it. I'm going to stop
questions
sharing
for-
so that I can see everybody.
Do people have questions for Dr. Gillespie? Just go ahead, take yourself off mute.
I know that was like a bullet train version of the presentation, so I apologize. Should have told you to buckle your seatbelts.
Thank you. No, it was awesome. I definitely feel like I've taken a few sips out of the fire hose though. I was like copious, like kind of taking notes, like it's recorded. Just a few questions. Some were simple kind of yet, but for the brain growth that was found after birth, is that for both moms and dads, or just is it like a physiological, the pregnancy and delivery, or is it for just parenting in general, like even for adoptive parents?
Yeah, it was both moms and dads. It was a little bit more in moms, but dads did have some of that experience as well of new brain growth. She didn't study adoptive parents specifically, so I don't know that answer, but other than that, it was in both genders. So it seemed to be more related to the experience of parenting.
Very cool. Is there currently a screening tool that does combine ACEs and the positive childhood experiences, or is it okay? Good. So it's okay. That's already out
Yeah,
there.
the one that I use does that. So if you don't have that, and we can talk about the structure, but mine is, first page is the cover letter. Then the second page are the ACEs that are aggregated so that you don't have to tell me which ones, you just count. And then we have some added ACEs, like some of the community ACEs that are in there. So there are 14 of them altogether. But then we added in a question that says anything else scary or upsetting that happened to you during your childhood, to kind of open it up into the idea of it's not just the ACEs, it may be something else that we don't know about. Then the next page are going to be the positive childhood experiences. And then I ask, of these, which are you most excited to have your kid experience? And how are you doing with making that happen? And there's an I'm doing great, I need help with this, or I don't need to talk about this right now. And then the back page is just like any other comments and then who filled it out, so I know if it's mom or dad.
Oh wait, awesome.
Yeah, so I can share that with you if you
We've
don't
done
have
some
it.
small modifications of Dr. Gillespie's, and that's the one that we have shared with you all, and really want to encourage you to use it. But that's a discussion we should have as we, as we
Right.
end this
Okay.
process.
Yeah, that was
with-
discussed
with-
at the first session, and I'll send that out again with the notes.
Okay. Yeah, no, I remember seeing it from the first session, but just I didn't. Anyway, thank you.
Yeah, it has both on there. Yeah, awesome.
Then,
Good question.
For thinking about like not just our current providers, but for the next generation of pediatricians, are there any programs building this into their residency training? Since we're about to open up our own pediatric residency program here, like, are there training resources beyond this, or this is what we'd say, no, just introduce to your residents from the get-go?
Not universally. I think that there's sort of a movement towards, at least an understanding of trauma, but not in terms of how you build a trauma-informed practice or trauma-informed system, right? Like, I think it's still very much lacking at the training level. So I just had 4 providers join my practice this last summer, and I'm going to have to set up a new training for all of them on how to do this, right? And I told them, just don't do it until we can get a chance to talk through it. But no, they're not coming out of training with that kind of knowledge yet.
Okay.
Unfortunately.
Awesome. And then this might just sound like but the basics of, how every visit has a flow to it. Like when you do the
Yep.
exam, when you go over the growth chart, when do you put this in your visit? At the end, when do you put this in?
I put it in closer to the end. So I usually do, kind of the going through parents' concerns, talking about development, make sure that we've kind of listed off what vaccines we're going to do. And then I do some of the basic anticipatory guidance, and then I turn to that. And I feel like just in terms of flow, it sort of warms it up. There's been one exception to that where I walked into a room and mom was fuming, right? Like I could see it when I walked in the room. I was like, uh-oh. And I saw that she had the clipboard in her hand. I was like, I guess we need to talk about that, huh? And she's like, yes, we do. And so I just started off the visit in that case, right? Because she was in that dysregulated camp in terms of like not ready to talk about it. And or not understanding the questions. And when I talked to her about it, she's like, that actually makes a ton of sense, right? So she was fine once I talked to her about it. But, if I see something like that, then I do it right off the bat. Because sometimes you walk in a room and you read the room and you're like, there's some big tension here. It's probably that tool, if that's, if you're seeing that, in which case I do it right off the bat to say, okay, let's just clear the air on that one.
Okay, awesome. Those are all my questions. Thank you so
Yeah.
much.
Yeah,
Tom?
if I can just add, I think the understanding of the brain growth probably relates to our affiliative hormone oxytocin and its ability to increase our bonding with a child, increase our synchrony with a child. And that's the most well studied. I imagine there are other hormones that are involved, but oxytocin in the midst of a shortage is our friend. And then, in terms of a trauma-informed curriculum, I would love to take the PEDS residency to a point where we interact with Dr. Brooks Kushen out of Salt Lake. He's a child psychiatrist. Part of his academic appointment is dependent or actually guides him to help residencies in the Northwest establish a trauma-informed care path. And that is something that I would be happy to head up for the PRI if everybody should agree that that's a direction we'd like to go. And it's a full set of curriculum that he has developed.
No, that'd be awesome because we're unique that we get to, I'm building out the didactics right now with Perry, so we could just build it in now.
Other questions? And I'll just remind you that you do have access to Ask RJ through our little email that we've set up. And we are planning the peer session with when Dr. Gillespie can be part of it too.
All right. Do
All right.
people need to take a break, or should I just keep plowing through? I sort of assume people will take care of their own needs as they come up. I'm happy to keep going just to make sure we get through everything, but don't be shy about going off camera, taking a break and coming back if you need to. Is that fair?
That's a good way forward. Yes.
Okay. All right,
Thanks,
so
Dr.
let me go back to the slide deck and oops. All right, here we go. All right, so, I hear a lot from pediatricians that, responding to trauma isn't necessarily in our wheelhouse as pediatricians. We're not mental health providers, but I think that's where I think the art of medicine comes in. Figuring out what's already in your toolbox is going to be what helps get you through these particular conversations. I talked about listening already, so I don't need to belabor this point, but again, this is the number one skill that you're bringing to the table. So don't underestimate that. The other study, and this comes out of the National Survey of Children's Health, positive relationships with providers matter for building resilience. And what they found is that kids that had 2 or more ACEs whose parents report that their child's healthcare providers always listen, spend needed time, and give needed information are over 1.5 times more likely to live in families that practice 4 basic resilience skills. Children whose parents report always having positive communication with their child's healthcare providers are again 1.5 times more likely to practice 3 or more of 5 recommended protective family routines and habits. These are things like reading daily, bedtime routines, stuff like that. So this is just coming down again to our relationship with our families and making sure that we are, again, always listening to our families as best we can. I would think that redefining our goal and our role is an important mindset to be in. First of all, I think that the success in our conversations about ACEs and trauma is relational. So it's not about forcing a disclosure. It is about making sure that the door is open to further conversation. And I've had many experiences over the last decade where at some subsequent visit after assessing ACEs, I've had families that have revealed all sorts of stuff to me domestic violence, food insecurity, family strife, conflicts within the household, all that kind of stuff, because families understand that this is important to their child's development and that I'm willing to talk to them about it. That to me is the success of my program, right? I would rather have somebody tell me I'm dealing with domestic violence right now so that I can find them resources than to have them come in for a well visit and again have me talk to them about car seats, right? Like that's not going to be what makes that family well. I think we need to make sure that we are keeping our conversations validating, safe, and non-threatening, and that comes down partly to our body language. It's an important thing to make sure that we put aside our computers, that we put aside our notes, and just sit and listen, relax in a relaxed body language kind of manner to our families. If we are thinking about the writing reflex and thinking about what we're going to do to offer this family, that means we've actually checked out and we're not hearing the story. And I think it's really important to suspend that. The mindset that I always tell my staff is, instead of thinking what's wrong with this person, think what happened to this person, and furthermore, how can I help? So in other words, again, what is most required of you is your listening skills. And I think by listening to the patient, understanding their perspective, and probing for their particular needs, the plan is going to be obvious. And again, I simply go to, what do you think would be most helpful right now? And if you think about the most challenging conversations you've had in clinical practice, again, to me, I always go back to all the kids that I've had with brain cancer, which I don't know if that's like cell phones or Diet Coke or what it is, but if you think about what your role was, what you offered the patient and family, and what made that interaction successful, conversations about trauma are very much the same, right? Like, so for those families where I was diagnosing them with a horrible thing, I was listening, I was empathetic, I put everything else aside. I got them the resources they needed, maybe not at the time of the visit. Sometimes I had to dig, but that's what made the interaction successful, was really about my ability to put everything else aside and be present for the family. Now, I put this in here because this is actually one of the ways that I manage the conversations for all ages in my practice. I have the 7 C's sitting up on a wall with a definition of resilience. So the 7 C's come from Ken Ginsberg's Fostering Resilience, and he wrote a book, Building Resilience in Kids and Teens. Those 7 C's are connection, confidence, competence, character, coping, control, and contribution. The websites here on the bottom, I think it behooves everybody to understand these 7 principles of resilience. So that's homework, I guess. This I'm a little embarrassed to put in here because I've written an entire chapter on revamping anticipatory guidance. I personally think that anticipatory guidance in its traditional form is extraordinarily boring. I once had the experience of a mom who came in with her 6th kid, and I think it was the 2-year checkup. And this was years ago. And I said to her, we're gonna talk about safety now. And she kind of slumped over in her seat and was like, oh God, here it comes again, because it was literally dozens of times that I talked to her about things like car seats. So I think that one of the things to think through is, how do we weave promotion of early relational health into our standard anticipatory guidance? Now, Nadine Burke-Harris's group promotes that there are 7 pillars of stress health. These are the things that are preventive in terms of stress not overwhelming you. Good nutrition, exercise, getting out in nature, sleep, supportive relationships, meditation and mindfulness, and good mental health. So if you think about those and think about the things that we do in anticipatory guidance, how do you actually weave those together to purposely and every day build relationships and families? For example, when you're talking about nutrition, instead of just talking about how half your plate's supposed to be fruits and vegetables, talk about family meal times and conversations for family meals that can include things like highs and lows, roses and thorns, 3 good things, so that you're actually figuring out how to turn a nutrition conversation into a relationship building conversation. I personally, my goddaughter's family does highs and lows, where everybody talks about the best thing that's happened in their family and the worst thing that's happened, or the best thing that's happened in their day, and then the worst thing that's happened in their day. Roses and thorns is the same thing. 3 good things is a positive psychology technique where people who practice gratitude, as it's called, have less depression and less anxiety. So this gets down to everybody in the family sharing 3 good things that happened to them that day. Exercise and getting out in nature, again, we tell our families all the time to go out and get more exercise, that you're supposed to do an hour a day or whatever. But turn that into a connection opportunity, right? Like, what can you do as a family that's active or with other people that's active, and setting small, smart goals about that, to make it, again, not just a physical activity thing, but a connection and relationship thing. When it comes to getting good sleep and making sure that families have solid bedtime routines, that is a time to talk about special time or time ins. Reading is a part of that, right? Where if bedtime routines are, again, a chance to connect parents and their children, then you've not only talked about the importance of sleep, but you've talked about how to make that a connection moment. I think the supportive relationships in terms of teaching parents resilience skills and teaching positive parenting, we're going to talk about that more in a minute. Meditation and mindfulness, I have a couple of different quick breathing exercises that I can teach, and often model them in the rooms, right? So square breathing, fall off breathing, and belly breathing are three of my favorites. Square breathing is when you breathe in for 3 seconds, hold it for 3 seconds, breathe out for 3 seconds. Fall off breathing is when you take in a deep breath, take in a little bit more, and then huff it all out at once. These are great things to teach kids and families. And I oftentimes, when I see kids that are kind of bordering on anxiety, bordering on depression, I'll have that be part of the mealtime routine as well, so that you start off with a couple of square breaths, start off with a couple of fall off breathing exercises. Belly breathing is when you put a stuffed animal or a ball on the belly of a toddler who is laying down, and have them breathe in and breathe out and see how the ball is moving up and down. And then I think the last part in terms of good mental health is assessing and teaching coping strategies. And I love the question of what helps you stay calm and in control when faced with a challenge. So this is how we kind of turn anticipatory guidance on its ear a little bit. So it's not just us nagging, but us figuring out opportunities to build relationships in families by supporting the things that we're already talking about. All right. Again, I apologize. This was a super short version of a much longer conversation, but I think you can get the idea from what I'm putting out here. Positive parenting. I think there are 3 basic assumptions in positive parenting, and this comes out of Ken Ginsberg's work as well. And this by itself is an intervention. Talking to parents about what positive parenting means and the 3 assumptions is an intervention for kids. And I talk to every parent of every 12-month-old about positive parenting and discipline in an intervention that I can teach you at another time. But these 3 assumptions, that kids raise or lower themselves to whatever expectations we set for them, which is to imply that we keep our expectations for our kids high. Second is that parents should express unconditional regard for their child. So you love the child even if you don't love the behavior. And third is that kids learn more from what they see us do than what they hear us say. I think that part of, again, parent education involves teaching these assumptions early on. I also make sure that I point out that you're going to have good days and bad days as a parent. How you are most of the time is far more important than how you are all the time. And so that's kind of the concept of good enough parenting, right? So I'm sure that everybody here has their own positive parenting techniques. So maybe write it in the chat to share with each other. But for me, some of the ones that I talk about the 5-to-1 ratio, so that for every 1 time you have to correct a child's behavior, you try to catch them being good 5 times. I talk about how kids in the toddler years who get 30 hugs a day have fewer tantrums, and things like that. So again, if you want to share your best positive parenting technique, this is already in your wheelhouse. I think the other piece in terms of the art of medicine is, again, looking at how you read the room. So what's the nature of the conversation I'm having after a parent has completed an assessment tool? So as I mentioned, one of the visits that I had not that long ago, I walked into the room and the mom was mad, and she was kind of clutching the clipboard with the screening tool. And so I knew that was kind of an anger, skepticism kind of conversation. I have many other families who are just curious and grateful that we're asking the questions. And so again, if you're seeing that sort of dysregulated, reassurance, empathetic listening, talking about the purpose of the tools, and again, mostly the reassurance is about what you're going to do with the information, and then you figure out a follow-up. If the conversation's regulated, then you're going to do education and resources and the development of a safety plan, which we'll talk about. I want to run just through some cases so you get an idea of what the conversations have actually been like. And these are sort of high level. again, how some of my everyday conversations go. First one is a 4-month-old in for a well visit. Colic is the big concern. The kid cries 3 or 4 hours every evening. So I'm sure we've all had patients like this. It's a 2-parent household, 7-year-old sister at home. Mom works full-time. Dad's in training to be a firefighter, which means that he is out of the house for 2 days at a time, back in for a day, and then back out. So mom is more or less doing this on her own. So she leaves work, immediately drives through traffic to get home to relieve the nanny. So she's rushing into this, crying kid every day. There's really nothing else on his physical exam that makes me think there's anything beyond just plain colic. But when I talked to mom about her ACEs, she has an ACE score of 5. So her parents went through a horrible, aggressive divorce. There was verbal abuse, there was domestic violence, there was substance abuse. And so her reaction to a yelling infant, right? Like, because she grew up in a loud yelling household. And so hearing this yelling really was kind of triggering her fight, flight, or freeze response. So when you have that kind of a conversation, what do you do, right? Like, what's the thing that's going to be the most helpful? Again, if you want to put anything into the chat, feel free to kind of share how you would do this. But what I did is I kind of probed into what mom normally did to keep herself calm and in control when faced with a challenge. And she identified yoga as the thing that she used to do, but with a new baby, she wasn't having time. So if she doesn't have time for yoga class, how does she carve out a 15-minute chunk of her day to breathe, relax, and recharge? And really what she ended up doing was stopping for a cup of tea on her way home. So it wasn't this rush. She would take just 15 minutes to herself. And 2 months later, everything was better. Mom was more relaxed, so the kid wasn't crying as much, probably because of that. The crying was less, perceptions were improved, and so forth. And so I think that the punchline on this one is that parents often need permission for self-care. And they may not always be aware of how their own experiences affect how they handle parenting, stressful situations, or work-life balance. And so I think this is an important conversation. Now, when we get into those resilience interventions, and somebody put a footnote on this, but I now talk to every family of a 2-week-old about self-care. I use a baseball analogy to help give parents this permission for self-care. This is one of the interventions that I now do on everybody. Second one, and this is one of the more challenging conversations, in that mom actually did cry through most of the conversation about about ACEs. And so this is a Hispanic mom. She has 3 kids. The 16-year-old I'd never met, 5-year-old, and the 4-month-old. And when I talked to her about the ACE screening tool, she said that her dad was an alcoholic. There is domestic violence to the point that she feared for her mother's life, and that dad was physically and verbally abusive to her and her sister. And her sister is now married to the same kind of guy, so an alcoholic, abusive dude. The 16-year-old daughter dropped out of school, and she's been pregnant, moved back to Mexico to live with extended family, which is why I'd never met her before. And so her big thing, how do you think this affects your parenting now? She said, I don't want to make the same mistakes again. I want better for my children than what I had. And what I would just say, again, you can kind of think how you would respond to that conversation. But the punchline, again, is that listening is therapeutic. This mom comes to the conversation about ACEs with incredible strengths, right? She has determination and will to have her children experience something different. That is an incredible starting point. My response to that is that I'm committing to helping her figure out how to do better parenting for her kids, and that I will support her with that. And so I think that, again, getting back to that HELP mnemonic, the common factors approach, partnership and empathy were the 2 things that I really leaned on for that family. And, we always have parents that are emotional for different reasons. We don't necessarily have to have the answers. But again, empathy and partnership go a long way. So my key message, again, is you're not alone. It's not your fault, and I'm here to help you. This is one of my favorite stories. This is a mom of a 4-year-old who is concerned about his behavior, because whenever she disciplines him, he laughs at her. And mom is, as she's describing how frustrating she thinks this behavior is, the veins start popping out of her neck. She is angry. And I said, why do you think he laughs? And she said, I don't know. It's so frustrating. He's such a little and we'll bleep that next word out, but you get the idea. So what do you think you're seeing and what would you do? Obviously, we're talking about parent ACEs. So when I asked her about her background to get a sense of why she thought he was laughing, she'd been verbally abused as a kid, and she interpreted her son's laughing as that same kind of humiliation. And as it turned out, when you ask what happened after the giggle, a minute or two later, he'd always apologize and say, "Sorry, mommy." And when I asked her to kind of reframe his mindset, and maybe he's not a little fill in the blank, maybe he's embarrassed because he's being corrected, and then her shoulders dropped and she was like, "Oh." And so then the positive parenting conversation was really about how she centers herself when she needs to correct his behavior, taking a deep breath, reminding her why she's doing the correction and focusing on her goal of the correction. And then we talked about the reinforcement for positive behavior so that she would have to do less of those particular corrections. So I think that the punchline on this one is that kind of helping mom connect her childhood with how she was reacting. She had kind of put the same characteristics of her abuser on her kid, which made her misinterpret the reactions. And so it was really kind of helping mom understand that mantra from collaborative problem solving that kids do well when they can. And an understanding of development is really a skill set that you have in your tool belt, right? That mom was misinterpreting her kid's reaction because she didn't understand the development part about, 4-year-olds really aren't stubborn or selfish or mean. They're doing the best they can, right? And so teaching mom a self-calming activity is a trauma-informed intervention, because if she's able to take a few breaths when she hears her kid laugh and recenter herself, she's showing her kid what to do when she's angry, right? So now our kid knows that as well. So just a couple of cases, but now let's talk about the specific nuts and bolts about what you're going to do with your patients who have experienced trauma now that you know how to navigate the conversation. So what do we do next for the family? And I think if you think through a basic medical home workflow, the first is to identify a population through screening or surveillance and track them. So that's what we're doing with our assessment tool. Second is to assess family and patient strengths or assets and the needs for specific services. And again, that gets into our conversation prompts, like what are the specific services or resources that a family thinks they need. Then we make those referrals. Then we do our self-management tools, which can include a safety plan, although frankly, I do that far less with our parents, far more with kids that have experienced trauma. And then we do our developmental promotion. And then we make sure that we follow up on any referrals so that we know that parents actually got what they needed out of the referrals that we make. So this is a basic workflow. And I think everybody can kind of interpret how their clinic fits into this particular workflow. But if you think about all of the different colored boxes, these are different people that are involved in the process, right? So the blue is going to be your front desk staff and your scheduling staff. Purple is the patient. Orange, it depends. Green is usually the provider. And then if you have people to do care coordination and you have people to do behavioral health, then those are going to be different people. But once you have a well child care visit made and the patient checks out or checks in at the front desk is going to be handing out the assessment tool and explaining it to the patient, right? So you know that you have to have on your team somebody who does this work, right? The patient completes the screen or not if they choose not to. So you should on your planning team have a patient if you can. We can talk about that more later if you're interested. The orange means it kind of depends on whether it's your nurse or MA that collects it and scores it, or if it's the provider. And a lot of times that comes down to how fast patients and parents can fill out the tool relative to when the provider comes in the room. I think that the discussion is provider work, right? So you review the results, discuss it with the patient. If it's negative, you will give resources as needed. If it's positive, resources and referrals and results and action plan are documented. And then again, figuring out some system for how you're going to make sure that families respond or get the resources they need and that those resources actually were helpful. If you have a behavioral health person in your team, hopefully you can get them involved as well. But like I said, a lot of people that are potentially involved in this. So in your planning teams, think about having all of these people involved. In terms of the specifics of staff roles and how to make this work a little bit more easily, once an appointment is made for well childcare, does the scheduler have scripting for preparing the patient that the visit is going to include some screening tools? And can the scheduler ask the patient to come in 5 to 10 minutes early to help create time to complete the tool? When the patient is checking in at the front desk staff are going to have a protocol for identifying when screening tools are being used and make sure that those are all supplied and that they have all the tools that they need. And then in terms of giving out the tool and explaining it to the patient, you're going to have some scripts and some training in terms of explaining the tool for the patients. And again, giving the message that it's a universal thing. This is something we do for all our families to help them in their parenting journey. We're not assuming there's a problem, but we're just using this as a way to help figure out who might need some extra assistance. You can consider, again, a brief cover letter as part of that messaging. Again, you're going to have to figure out in your practice who's stocking the tools or otherwise making them available. And then who helps patients with language and literacy concerns, and how do you assess whether somebody's able to complete the tool? And then as you change your screening protocol, somebody's got to be responsible for making sure the front desk staff actually gets the message on that as well. Nursing staff role, and again, this they may or may not be collecting and scoring the tools depending on how fast families are. Nowadays, most families are completing it in the room after they've been roomed, but it may be helpful for the nursing staff to figure out when patients need help or more time to complete the tool, or even recognizing when patients haven't even started to do it and to encourage them to do so. And then making sure if they're collecting the tool that the provider actually sees the results of the completed tool. The provider role, I think, is really about discussing the results with the family, figuring out again what resources are needed, and if you have any decision supports that are needed for recognizing normal and abnormal screens. Within our electronic health record, I've actually programmed in, or had our IT staff program in, those 3 questions, so that at the side of where we document things, you have the 3 questions about, do any of these experiences bother you now? Of those that don't, how did you get to the point they don't bother you? And how do you think this affects your parenting now? So that every provider has that there at their fingertips in case they forget, right? And again, if it's a positive tool, then assessing for referral and resources. And then if it's negative, does the patient still benefit from resilience or resilience promotion tools or other resources? And that, again, is going to be largely up to the family, although I think everybody should do some resilience promotion. In terms of assessing family needs, again, I think the best pathway is to ask the family. So as I've mentioned a couple of times now, part of the purpose of those conversation prompts are to start building that basic safety plan. So if there are experiences that still bother the family now, what do you think would be helpful? And if they don't say anything, then you can certainly ask, do you think a counselor or mental health provider would be helpful? And if those, again, experiences that don't bother you, this is looking at resilience. Do they still feel like they have those resilience factors now? Now, the circle of support intervention, I think, is a great way of identifying sources of connection. And I do this, you can do this pre-printed on a piece of paper, but I'm also often drawing this on the exam room table paper, where you draw a target. And in each of those 3 circles, the primary circle, which is the center of the target, you ask families, now, who are the people in your life that you can call anytime, day or night, for help if something goes wrong? And you ask the family to actually write in who those people are. Secondary circle are people, that you would say something like, who are the people that you hang out with on an occasional basis that you could, get in touch with for, coffee or to hang out for a little while. And then the tertiary circle are the people who are there to support the family when they can't find anybody else. So these are going to be people like you as their provider. If they are members of a faith community, maybe the pastor, priest, rabbi, etc., and so on. So this is one of the interventions that I actually have people do. So if they actually write out and draw out a diagram of their support network, I think particularly for new families, when you are sleep deprived at 2 a.m, you can't remember who your support network is. So having this all written out is very helpful. Now, if you have the circumstance where there's nobody in the primary circle, you do what's called a secondary circle push, where you ask the family to identify somebody in their secondary circle that they would feel comfortable calling and saying, hey, I'm having a hard time right now. Would you be able to get together with me this week just to talk? And my psychology colleagues guarantee me that there's no human being that's going to say no to that request. And so what you're doing is inviting somebody from the secondary circle to be in that person's primary circle. Now, this is something you can do universally at newborn visits or 2-week visits. I think it's a very important intervention. I also would say do this in the context of parental depression, and do this in the context of adolescent depression. This is a very useful one for teens who are having depression as well. So this intervention, I think, is a nice ubiquitous one, which is why I put it in the presentation. Have this one in your pocket though. So people have been asking for some of the interventions. That's one of them. It doesn't honestly take that long to go through, but if you're having a family that is experiencing trauma or a mental health crisis or a teenager that's having depression, there is nothing more important in your visit than doing something like this, right? In terms of finding resources, and I didn't have time to look in Idaho specifically about what resource clearinghouses exist for you, but these are some of the things that you're going to want to look for. So if you can find a clearinghouse, something like 211 Info, United Way, Help Me Grow, Unitas, Aunt Bertha, or something like that. These are basically organizations whose job it is to find community resources. So they'll be the ones that keep lists of parenting classes, of developmental supports, of childcare resources, and so forth. There are other county agencies that do some of this list making. So most counties have a Defending Childhood initiative, which would have domestic violence resources. Community Action is a county-based program as well that helps with some of the social determinants things. And most early intervention, early childhood special ed organizations will have at least some referral lists as well that you can start with. Again, my bias is to make sure you have at a minimum some parenting classes and parent support groups in your area, because that's by far the most common resource that people are asking for. Mental health providers, and this was one of the Ask RJ questions that came out today, so you'll get this in a minute when Liz sends this all out, but the two that I always use, Postpartum Support International has a chapter in every state, so they have at least some contacts to help with sort of the warm handoffs and the support groups for families that are experiencing postpartum depression and anxiety. And then I use Psychology Today to find lists of trauma services for parents if needed. So I've had that happen again about 5 times. And what I did, well, first you can probe to see whether or not the family has still connection with a primary care provider, an OBGYN, or a mental health provider. And if they don't, then I turn to Psychology Today. And what you can do is search by zip code, and then you can filter it by trauma services and filter it by insurance types, and come up with a short list of people in your area who do the kind of work that we're talking about. Some other public health and community interventions to have as resources, nurse family partnerships and other home visitation programs. 2 home visits in the first year is shown to reduce child abuse by 50%, right? So for families that are particularly vulnerable and who are eligible, home visitation programs are a great resource for preventing ACEs. I would say that many families are resistant to home visitation programs because they, again, of the concern of like having a government agency looking in on them. And so I think that we can be deliberate about our messaging, that they are there to support and to help, but not to report and to condemn any families. I mentioned some of the community referral agencies, early intervention and early childhood special ed. Those are often a parent coaching model to improve interactions between parents and child. So there are some states that use family risks as qualifying diagnoses. For example, Illinois uses maternal depression as a qualifying diagnosis for early intervention. So I think this is a major advocacy opportunity, that if all of our states actually use things like maternal depression and parent trauma as qualifying diagnoses, we would have a lot more families getting help. Knowing mother-baby dyad interventions. So these are like the attachment biobehavioral catch-up would be one of the therapies. The other one would be the parent-child interactive therapy. These are great things to know in your community which ones do that. I've also referred some kids to mentoring programs. Those are usually the older kids. So doing things like Big Brother, Big Sister programs, Boys and Girls Clubs, so that you're helping to form safe, stable, nurturing relationships when the family is not able to do that themselves. And a lot of schools are actually becoming partners with us on this work as well. These are some parenting interventions with good evidence that work. So these are again the kinds of therapies that you're going to be looking for and parenting classes that you're going to be looking for. I'm not going to read them all to you, but you'll have them in the slides when we send those out. So again, these are the kind of referral resources that you're most likely going to want to have to dig out of your communities. The universal resilience interventions, like I said, I've been talking about this a lot. We've been working on making sure that all of our trainers are trying to do that. We trained everybody right before the pandemic, and so that, you know, there are some of us that are doing it a lot and others that are doing it less. So we're going to loop back around once everything semi-normalizes and train everybody again. But really, those interventions relate to parent self-care, promoting attachment and attunement, and building resilience in parents. So the circle of security or circle of support intervention is one of them. The baseball analogy that I talked about is one. Talking about time-ins and special time. I talk about mirror neurons and mirror work at the 2-month visit. Talk about attachment at the 4-month visit. We talk about parenting styles and discipline at the year visit. Those are the sorts of things that I think help families to become stronger. And again, it was too much to put all of them into this presentation, but I can kind of chunk them out if they're ones that people are particularly interested in, so that I can teach you some more of those so you have those under your tool belt. There's the list in terms of what we do. 9 months is kind of a review, but all the other ones we teach them something different. So what it looks like in our clinical response, regardless of the ACE score, right? Like, and I think this is something to think through. So as I mentioned, in California, they're talking about a positive tool being 4 or higher. And I think that a positive score is any disclosure if the family thinks that it's a problem. So for every patient, we're doing the universal interventions, the resilience interventions, and we're doing education about trauma and resilience by talking about trauma and resilience when we do our tool. And to be very specific about that, when I get a tool back from a family, before I even open it up, I make sure that they understand what we're doing, that we've had a conversation about ACEs and resilience, and that their information is completely confidential, that I'm the only person that's going to look at it. Then I open up the tool to see what they actually said. That way I know that I'm talking to everybody about trauma and talking to everybody about resilience before we even get into the nuts and bolts of their disclosure. So anything other than 0, I ask those 3 questions to get at a safety assessment and to figure out what resources they need. I will either refer to my care coordinator if it's a social need, or help me grow in my community if it's a developmental need or a social emotional support need. What we are working on in our older plan before the pandemic, what we're going to work on is for any patient that came up with a positive and symptom or safety concerns, we were planning a joint 6-month visit with our behavioral health consultant to do some social emotional development screening and a video interaction intervention. That's on pause. We're hoping to still build that in, but I think that's going to be like the Cadillac version of supporting families once we get that all done. So more to come on that, I hope. This is what a shared care plan would look like. And again, I do this more often in teens that have mental health problems, but it is certainly something that you could write out for a family if they're having severe trauma. And I think the value of writing this stuff out is similar to the value of writing out the circle of support, in that when you're in a crisis, it's hard to remember all the things that we talked about you doing to get yourself better. So the basic components of the shared care plan would be the contact information for any providers and counselors and people like that in the office, some information for the patient, how they identify when they need help, right? So what are the behaviors, thoughts, or feelings that tell the parent or family that they need to reach out to somebody? Next part is potential coping strategies to utilize until they can reach out to that person. And again, the circle of support I would put on the back of this. And then the last part is information about any referrals that were made and who's responsible for following up on those next steps in terms of who's initiating contact and so forth. Those are references. And at this point, we're back to being able to ask questions. I know I went through that very quickly. but I want to give more time for questions just in case there are any.
Hey, me again.
Yeah, go for it.
I was wondering, do you, so we've been talking about it kind of with our group session of like when to do this, and we're talking a lot about doing it the 4-month well child check. But what do you do for if you have new patients that are older, or if you already have established patients that now you're in, like, do you just say, oh, well, I'm missing those, I'm just gonna do my 4-month-olds and on, or how did you approach that?
Yeah, so we don't have a system for going back and screening people who missed a 4-month visit or who came in after their 4-month visit. But I would think that part of what I guess I've always thought is that it's not, again, an individual one-time process. It's a more longitudinal one, right? And so for a lot of the families that come in later, I'll ask them more targeted questions about, how they were raised and how they think that affects their parenting, or for, a lot of the school concerns and mental health concerns and so forth. Just asking the question, did anything scary or upsetting happen when these symptoms started, will get at the trauma question, right? So I think that having some of those surveillance questions in your back pocket. So like that case that I told you about, the 4-year-old where he was laughing every time mom corrected a behavior. That was somebody I didn't know at the 4-month visit. And so we had the conversation when it was relevant, right? Because she is asking about behavior. And so we turned it into a conversation rather than about a specific screening. And so to me, I've always seen the screening tool as being more of a way to open the conversation, but it's not the only way to open the conversation, right? And so if you have other circumstances where the family hasn't been screened for whatever reason, that's not as important as actually getting to the point, what I mean, about like how they were raised and how that affects their parenting. We chose the 4-month appointment specifically for a couple of reasons. One is the idea of, we looked at a screening grid for one thing, where if you put just a grid of all the different appointments and all the screening tools and pieces of paper that you have to hand to a family at every visit, there's a lot on there, right? So if you have your maternal depression screens, your developmental screens, your lead and TB screens and so forth, 4-month-old, there was a hole, right? There wasn't anything that we were actually doing at that visit. So that was one reason. Second reason is that we wanted to actually know the families at least to some degree. Right? Like if you ask it at the very first visit when the people don't know you from Adam, it's a little bit intimidating to be asked questions about your personal history, right? Third reason is that at the 4-month visit, we've already done a couple of screens for postpartum depression. So the families are already getting the message that we care about their health, right? And I think that was an important factor. The last is that 4-month-olds are normally like the happiest critters on the planet, right? You do anything halfway right, parents have this great feedback loop. The kid coos, the parent responds. So it's a great time to kind of build on that. You know what I mean? So it felt natural in terms of that's why we did it then. So I would highly recommend that you think about those things. What's going to get in the way in terms of other screening tools, right? How well do you know the families? And where are the parents in terms of their parenting journey? I think most people by 3 months kind of feel like they're in a groove. They've kind of gotten things are clicking. And so 4 months is a nice time to kind of pick up on that, if that makes sense.
Okay, great. And no, that makes sense. And then if just to the group in general, but I would love to hear more on your resiliency interventions. Like literally every word you said since 12 has been brand new to me. So thank you.
Okay.
You don't have to do them now, but just
yeah,
I would love to hear more about those as we go through all of.
Yeah, we can certainly brainstorm how to get that information out to you guys. Because part of it is a script, but I think most of the time it's helpful to kind of hear how somebody talks through it. You know what I mean? But yeah, so circle of support is one of the big ones. But yeah, I'll figure out how to get those other ones to you in a way that's useful. Yes.
Thank you.
One quick question that may have been covered before, but when two parents or both parents are coming or are there at the visit, do you usually try to provide 2 different questionnaires for the ACEs and the positive childhood events?
Yes. Yeah, we usually do. We do ask both parents if both parents are there. We don't have, again, a way to kind of make up if one parent wasn't there. But, certainly, some of the follow-up questions that I ask at later visits in terms of family functioning really have to do with like, how are you and your partner doing on staying on the same page with parenting, where your experience is a lot different than your partner's and so forth, so that you can kind of get a sense of how they're doing, less like a, mom versus dad kind of a thing, but how are you cooperating together and how are you integrating your own experiences and each other's experiences in terms of understanding how you're parenting. So that's, I think, part of the subsequent conversations regardless. So if you don't have both parents, then you can do some of those sort of surveillance questions to just ask, if they're all on the same page.
Thank you.
I'm going to, you might be thinking some other questions. I'm going to use this time to make a few announcements. So we do have our independent work then. We are going to ask you to actually fill out 2 session evaluations, and I'll send those links. I'll put them in the chat, but I'll send them out by email right after we get off. Because one's for this, whatever, just take our word for it. Thank you. Neither of them are that long, but this is for your CMEs. I put in the chat that we do have these resource packets that we're going to be getting in the mail to you. And we can go through all the different resources, and there's some books in there for you and your staff, and to you could loan them out to your patients, your families, if you'd like, and a lot of fact sheet type things. But we didn't make any copies in Spanish yet, but if you want us to, that's in our budget, and we can send you some copies in Spanish. But we're going to need you to tell us that you indeed would like those. I put the link to what all the resources are. It's on the same page that you went to read our guidance for pediatricians, or to look at the recording from the last session is also there. To go ahead, continue to meet with your parental ACEs screening team. There's an excellent movie video that we like, Wrestling Ghosts. It's 90 minutes. We couldn't figure out how to buy it for everybody. I think that they are not, active anymore, the directors and producers of it, but you can get it. You can, rent it out for $7.99. It's 90 minutes. It's very powerful. It's about a parent overcoming their ACEs. Working on your readiness sustainability plan. We're going to provide you some more links to some of the community programs, some that Dr. Gillespie mentioned, and you'll be able to kind of do a little pre-work on that. As we said, then our next session on December 3rd is we're going to have a lot of guest speakers. We're going to be introducing you to the people who do the 2-on-1 program and stuff in Idaho, the Head Start program, some of the other resources. All right, so here's the big news. So I was able to talk with Dr. Patterson. The peer session is going to be November 10th at 12, from 12 to 1. That's a Thursday because Dr. Gillespie can come. So Dr. Gillespie and Dr. Patterson will be there. I'm not sure if Dr. Davis will be able to attend or not. If you can't make it, because of course you already have 10 patients, scheduled for that time, we can figure out how to get set up another peer session. Maybe you guys want to do them at 5 at night or 6 in the morning. I don't know. And then again, email at least one question to Dr. Gillespie. I think you probably will continue to have a lot of questions after today, and we'll get you, of course, the recording and the slide deck. Okay. More questions from today or about the whole ACEs, our collaborative? You guys still out there? I know you're there. Okay. Okay.
Well, just thank you so much, Dr. Gillespie. This was just really, really awesome. Thank you so much for your time.
Absolutely. And I feel like this will probably be a little bit of an iterative process. So a lot of the stuff I said, if we need to go more in depth or whatever, I'm happy to support you all in how that happens. Okay.
And one of the things that we've said is that, is really what we think is important is this longitudinal information, across the time, and that, Dr. Gillespie did just give us a fire hose, which we will then sprinkle out a little, I can't make the metaphor work, whatever, we'll do squirt guns later, and, just kind of, as you start into it, we also hope that that'll be an iterative process where you'll have an opportunity to do something, and you'll go, nah, that didn't work the way I wanted to, or man, that was amazing, and I want to tell everybody about it. So hopefully both things, we'll have both of those things happening in those peer sessions, as you go forward. And since many of you are from the same practice, you'll also have opportunities to kind of, share that together. We may very likely deliver those boxes, since most people are fairly local. You can probably figure that out more than mail them, but I'm thinking, but anyway, the boxes are great, and we'll do some walkthrough on that. If you have ideas too about things you'd particularly like us to focus on in terms of resources, please let Liz or I know, so that we can do that. We'll identify the ones that we're familiar with, which, is a lot of the resources in the community. And, but if there are things that you might want to hear about, and let us know.
Hey, let's give a big round of applause to Dr. Gillespie. Do doctors who give presentations get rounds of applause? They should, for sure. That was an incredible presentation. So well organized, well delivered, a huge amount of stuff. Thank you so much for putting all that effort into it. And I don't know, you're gonna have to go drink a bottle of Gatorade or something.
And Liz and I were skeptical that Dr. Gillespie could actually run through all those slides in one shot, but man, you did it with time to spare, I guess.
But don't let his skills intimidate you, because remember from last time what he said on the recording: if he can do it, you can do it. And we all, if you guys need a little pep talk, I'll give it to you. You guys can do it. You can do it. No problem.
Absolutely.
All right.
Dr. Omer, did you want to say something, because your mic was open, or maybe you just didn't close it?
Oh, sorry. No, I'm good.
Okay, just wanted to make sure.
Thanks.
All right.
Have a good day.
We're going to let everybody go.
If Tom
Excellent.
can
Thanks a
do it, you
million.
can definitely do it, says Tom.
That's right. Exactly. Exactly.
Bye.
Bye, everybody. Thanks a
Bye,
million for
everybody.
being here
Thanks.
with us.
Thank you.
I know.
Stay on for a sec here, y'all. Well,
You. Oop, let me turn the recording off.
okay.
First order of business.